today we have a topic of anemia, which is a very relevant topic. Though it is the oldest and the simplest to treat, we still are facing it in everyday practice. So today we'll be enlightened about the diagnosis and the management of anemia by all the stalwarts from all of Karnataka. So I welcome you all to today's session, and we'll start the session by invoking the God. Arun, please pray the prayer.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव
सर्वकार्येषु सर्वदा.
Thank you so much, Arul madam.
Nice.
Now I invite our dynamic president, Dr. Bharti Rajshekar madam, to give her presidential address.
Good afternoon, namaste, namaskaram, vanakkam, and I think vanakkam sir in Malayalam also to all of you. And it is indeed a great privilege for us to have all the four corners of India on this webinar of Gyaan Sangam, which was instituted just to see that we meet all our friends from far and near and share our thoughts on this. At the outset, I would like to welcome our chief guest for the day, Dr. Kunju Mohiddin sir, who is the president of the Kerala Obstetrics and Gynecological Society. And we are much obliged, sir, for you accepting our invitation at a very short notice. We extend our warm welcome from KSOGA Gyaan Sangam to this webinar. And then we have my very own dear friends who have readily accepted to be the guest of honors for this Gyaan Sangam, which is around the 10th or 11th program of ours. We have Dr. Mitra Saxena, who is the FOXY chairperson of the Practical Obstetrics Committee. We welcome you, Dr. Mitra ma'am, to this Gyaan Sangam of KSOGA. And then we have Dr. Suman Sinha. She is the FOXY chairperson of the Vaginal Surgery Committee. And I know that vaginal surgeries is something that is to be taken up by most of us and very promising techniques that we can follow. We welcome you, Madam, to Dr. Suman, to this webinar.
Thank you.
And we have our guest speakers, Dr. Sampath Kumari, the immediate past Vice President of FOXY, and she has accepted to be the speaker of the day and to speak on anemia in pregnancy. We welcome you, Dr. Sampath, who is also a very dear friend to me. Welcome you to Gyaan Sangam. Then we have another guest speaker, Dr. Arulmozhi Ramarajan, who has her feet in two states. It's like the movie Two States. She was in Karnataka and now she's in Tamil Nadu, just like me. Both of us belong to both the states. And we thank you, Dr. Arul, for accepting our invitation and being here to moderate the panel on anemia in pregnancy. And we know we're all familiar with your academic proficiency, and we are, of course, looking forward to a brainstorming panel of anemia, a much needed topic today. And then I do welcome our own dear Dr. Vidya Tobi, the immediate past president, who will be chairing this, chairing the session on the panel, but also she is the convener, one of the conveners of the program and one of the brains behind this. We welcome you, Dr. Vidya Tobi. And I have my own KSOGA secretary, Dr. Rajeshri Palladi, who will also be a co-chair in this. And we have our dear panelists who will be interacting with Dr. Arulmozhi, and they will be, I think, answering all those googlies that Arul is going to bounce towards them. We welcome the panelists, Dr. I'm sorry, just a minute, just give me, Dr. Asha Nervi madam, Dr. Nagratna Guntoji madam, Dr. Shiv Kumar, Dr. Tamil Selvi from Tamil Nadu, Dr. Lakshmi KS and Dr. Deepa Reddy, who will be here to answer all the questions that Arul has for us. And I would fail in my duty if I fail to welcome the two young KSOGians who are always working towards the program of Gyaan Sangam, that is Dr. Shobha Shaivi and Dr. Rachna, who are always with me, helping me out. And of course, we have our patron, Chief Patron, Dr. M.G. Hiremat, who is busy with his college activities. We thank you, sir, for giving us this platform for us to spread knowledge. And my respects to Dr. Nagaraj and my immediate, and just before Dr. Vidya Thobi, President, Dr. Kasturi Donimat, who is also going to be an expert on this session. And I have my own secretary, Dr. Rajeshri Paladi, who has been with me for the past 1 year of my presidential tenure. I welcome you, Dr. Rajeshri, and I welcome Dr. Suman Gaddi, the treasurer, the President-elect, Dr. Durgada Sastrana, and all my dear delegates who have joined for this session, because however much we talk about anemia, it is surprising that still anemia is rampant in our country, and we have to continue to work towards disseminating knowledge about anemia and trying to eliminate anemia, especially among the adolescents and the pregnant women. We welcome you all to this warm webinar from KSOGA Gyaan Sangam. Thank you for the opportunity.
Thank you very much, madam, for your welcome speech. And thank you very much for giving us this chance. Now I invite you to welcome Dr. Kunji Moidin, sir, who is the chief guest for today's program.
Dr. Kunji Moidin, sir, as I already told you, is a dear friend and a very active academician from the Kerala OBGYN Society. And sir is right now the president of the Kerala OBGYN Society. He has 26 years of experience in ART and gynecological endoscopic surgeries. He is the managing director and chief consultant at ARMC IVF Calicut since 2009 and the ARMC Aegis Hospital in Perintalmana since 2018. He is a visiting consultant at KIMS RPC Dubai, a visiting consultant to Oman, and as I told you, he's the president of KFOG. He's been the chairperson of Kerala chapter ISAR and the past joint secretary of IFS and the founder president of Perintalmana OG Society, former consultant at Maulana IVF Perintalmana Kerala, and the founder secretary of IFS Kerala chapter. I welcome you, sir, and request you to kindly give the chief guest's address.
Good afternoon, everyone. Respected President KSOGA, Dr. Bharati, Secretary Dr. Rajshri, the past President of KSOGA, Dr. Vidya, the Foxy chairpersons and very dear friends, Dr. Mitra Saxena and Dr. Suman, Dr. Sambat Kumari ma'am, and all other faculty, distinguished faculty, and my dear delegates. At the outset, I thank the organizers for inviting me to inaugurate this wonderful webinar, Gyaan Sang. So that name itself is a very peculiar, that it's a knowledge sharing platform to everyone at the comfort of their home. So anemia, as everyone has mentioned, it is a very important topic considering the population of our country, and however much we discussed, it won't be an excess thing that we need to discuss and eliminate convey the knowledge to the grassroots level specialists, and we all should put all our efforts to eradicate anemia from the obstetric population as well. So that will go a long way to reduce the maternal as well as the perinatal mortality and morbidity in our country. So I bring all the greetings from Kerala Federation and I declare this webinar inaugurated. Thank you. Thank you for
Thank you. Thank you very much, sir, for your kind words and inaugurating the Gyaan Sangam webinar.
Thank you very much, sir. Thank you, madam. Now I call upon our immediate past president, Dr. Vidya madam, to introduce our guest of honor, Dr. Suman Sinha.
Dr. Vidya?
Vidya madam.
Hello everyone. It is my real pleasure to introduce my dear friend Dr. Suman Sinha. She is a chairperson of Vaginal Surgeries Committee, Foxy, which is a new committee, but she is doing a very wonderful work under this committee. Director, Advanced Care and Maternity Center, Ranchi, and Senior Consultant, HIVF and Infertility Center, Ranchi. She has got a very great experience in her OBGYN practice since 30 years. Ex-Chief of Medical Service and HOD OBGYN at CCL Hospital, Ranchi, which is a subsidiary of CIL. She was the president of Ranchi OBGYN Society 21-23, founder president of ISOPA, vice president of again Saudi Bihar and Jharkhand, and many more positions in Foxy as well as at her own place. She had many publications in index medical journals, invited faculty in national, state, and international conferences, and many awards. She was with me at MS Signature Award 23, and she was also a recipient of Duru Shah Appreciation Award. So over to you, Dr. Suman, and I expect you to stay back till the panel is over, and you had promised me that you will participate in panel as well.
Yes, madam. Yes.
Okay. So we need your words of wisdom for our KSOGA. Yes.
Yeah, madam. So, very good evening, everyone. And thank you, dear Dr. Vidya Thobe, madam, for the generous introduction of yours. It's a great pleasure and honor to share the platform with the Honorable Chief Guest, Dr. Kunj Mohiddin, sir, and Dr. Mitra Saxena, madam. I know Dr. Kunj Mohiddin, sir, is very a person of repute and very respectable person. And when I was contesting for election last year, he had been a great support and help from whole Kerala Federation. So thank you very much once again, sir. And Dr. Mitra, madam, she is a charismatic leader and doing very wonderful work in the practical obstetric committee. And she is very friendly to us. And to me, she is like a guide and mentor. So, madam, pranam to you. And then I'm really thankful to Dr. Vidya Thobe, madam, whom I adore always. We are really praising each other. So, madam, thank you very much for involving me here. And my friend, Dr. Bharti, thank you so much for bailing me out today. Thank you so much. And coming to the real topic, actually, the theme of today's webinar is on anemia. And it's such a challenging health problem till, in spite of so many governments projects are running to combat it, but still the prevalence is very, very high. Around more than 55% of our women are suffering from this disease, and it's affecting their reproductive health as well, leading to mortality and morbidity. So I'm sure from this webinar, very new things are going to come out to help us clinically how to manage this anemia, how to diagnose it. And I'm really thankful to all the organizers. So I want the academic session to start soon. So without coming in between this, I stop over here. And thank you and my pranam to everyone. And regards to Sampath Kumari, madam, who will be the speaker. And Dr. Arul, I'm so thankful to you at the last moment you've taken to moderate the panel. So thank you very much. And I'll be here. I promise I will be here as I committed. Thank you so much.
Thank you. Thank you, Dr. Suman.
Thank you, madam. Now I call upon our dear secretary, Dr. Rajashri Paladi, madam, to introduce the dynamic guest of honor of one more guest of honor, that is Dr. Mitra Saxena. Rajashri, madam.
Rajashri, madam is here. She is muted.
Rajshri, please unmute yourself. No, we can't hear you. You have to unmute.
Can you hear me now?
Yeah, now you're audible, Rajshri.
Pranamams and good evening and welcome to the beautiful session of Gyaan Sangama, wherein there's an accumulation and wealth of knowledge being shared all across. And it indeed gives me a very proud privilege and honor to be introducing one of the most brilliant academician we have in the Foxy, Dr. Mitra Saxena. Welcome to this program, ma'am. Dr. Mitra Saxena is the director of Shri Ashwini Saxena Hospital, Rewari, and is the chairperson of Practical Obstetric Committee, Foxy, 2021 to 24. And we see very active interactions and discussions which go on in the Foxy group, wherein Madam takes a very important lead to solve many problems put forth by the fellow Foxians. She has good number of publications, editor for the Foxy Focus, saving life-saving obstetric surgeries, e-bulletin, building bridges in Corona times, convener for the Foxy GCPR on birth after cesarean section 2023, member of the Foxy GCPR Ectopic 2020, various chapters written on stepwise devascularization, internal iliac artery ligation in PPH block, chapters on vacuum and operative vaginal delivery in the postgraduate textbook of obstetrics, and being a very active coordinator and administrator, she has organized many programs, state level conference in and hands-on workshop on ultrasound colposcopy, medico-legal issues, 7 physical workshops on internal iliac artery and anatomy department with cadaveric dissection. I think that gives a lot of confidence for the obstetricians to be able to handle the internal iliac arteries. Talks and online IIL workshops more than 15 to 20 times, organized online skill drill sessions, practical obstetrics and online surveys for understanding routine obstetric practice, scientific chairpersons in Ambala, member of various organizations like IMA, Foxy, DGES, IAHR. Ma'am, you have to educate us about DGES, Images, ISCCP, NARCHI, ROGS, HCO, ISAR, and HAROBGYN, received many awards, including the Foxy Diya Award in 2022, Foxy President's Appreciation Award at 2023, IMA Achiever Award of 2022, and her interests are high-risk obstetrics, ultrasound, endoscopy, infertility, contraception, and colposcopy. So, hearty welcome to this program, ma'am. And it indeed an honor and pleasure to be having you on this forum. Thank you.
Thank you. Thank you very much, Dr. Rajshri. Whatever is written in the CV, but you have actually raised my status very, very high. And it's been a fantastic, delightful journey in Foxy, you know, from trying to become a chairperson to being a chairperson. And more than anything, it's self-learning, I think. So I owe a very hearty thanks to all. And thank you, Dr. Bharati and the whole team, Dr. Vidya, who have invited us to be a part. You know, the advantage of being invited as a guest of honor is that at least you get to listen to a fantastically curated program, and also an opportunity to at least meet online my very good friends, Dr. Kunju, Dr. Vidya, Dr. Sampath. Just to see a glimpse of you people actually makes us also happy. So already everybody has, you know, I would just want a collective namaste to all of you. And may all of you really enjoy today's program, because what my personal take on wellness and anemia in pregnancy is, unfortunately, in our country, anemia is so well accepted that if a patient walks in with a report of 13-gram hemoglobin, then we are alarmed. Oh my God, she has HB13. We are questioning. Just look at the level of prevalence of anemia in our country. So, friends, to listen to talk, and to discuss this topic is extremely important. I always say that PPH and anemia, they are two topics, jitni baar bhi sune, utna hi kam hota hai. And then when we have speakers like Dr. Sampath and Dr. Arul, who is going to moderate a session on anemia of pregnancy, definitely it's going to be a case-based discussion, I think so. So, you know, they bring to the topic their perspective. Hardcore facts so wohi rehte hain, but the way they are presented to us, and some, at least I'm sure that every time when we listen to these topics, some new thing gets revealed, our understanding, comprehension improves, and where that will help us in managing our patient that is, how much you invest your time in these sessions, that will be directly proportional to that. So as an obstetrician, not being, cognizant of anemia of a patient is actually the first step to disaster. So I'm sure that Dr. Sampath and Dr. Arul, they will bring very important points in their talks and their panel. And I must congratulate Dr. Vidya, Dr. Bharati, Dr. Rajshri, and my dear young Shobha Shavi. I had the opportunity to spend very quality time with you in Bhagalpur. So I'm really grateful to you all to invite me. And I think that let's take the program forward. Thank you. And wish you all the best, Dr. Bharati,
Thank
for
you.
your journey in Foxy. After all those who are sincere and hardworking and who will give to Foxy, they have to be here. All the best, Dr. Bharati.
Thank you, Dr. Mitraji, for the warm words and for your blessings. Thank you very much.
Thank you, Mr. Saxena, madam.
Over to you, Shobha, to start the program.
Yes, madam. Thank you so much, madam, for your presence and kind words. Now I call upon Dr. Rachna as we move on to session 1 to learn about anemia from Dr. Sampath Kumari, madam. Rachna, please take over.
Yeah, I would like to invite the chairpersons for the first talk, Dr. Vidya Tobi ma'am and Dr. Rajashri Paladi ma'am. Can you please share the CV of Vidya Tobi ma'am, Arun? Madam
No
has
need,
been
Rachana. No need, Rachana.
Ma'am, just
Directly
a
you
brief.
put
I'll do it
Sampath.
briefly, ma'am.
Yeah.
Madam has been the immediate past president of KSOGA, and she's been the professor
That
and
is
former
enough.
head
That
of the
is enough.
Department of OBG, Alamin
That
Medical
is
College.
enough, Rachana. That is enough. Only 2 lines. And then let us move for the academic session.
I would also want to just mention that Madam is contesting for Vice President Foxy South Zone, and very soon I'll be saying she's the Vice President.
She is already the Vice President uncontestedly from South India.
From our side, she is.
Yeah,
Our side,
we
she
are all
is. Yes.
praying for just that, ma'am. Yeah. And she is the State Advisory for PCPNDT Board, Karnataka. She is the chairperson for Food, Drugs and Medical Legal Surgical Equipment. She has been for the year 2018 to 2020. She has received the Best Committee Foxy Award, Dr. Meheru Tara Honsotia Award. And she has been the Foxy Champion Award 2019. And she's been a great teacher for undergraduate and postgraduate students. I'll move on to Rajashri Paladi.
Yeah.
Please move to the topic. No, it's getting late.
Ma'am, it's okay. 2 minutes. I'll just check. Madam is our beloved secretary for
Just
this year.
go ahead, Rachna. Move the topic. Move the slide to the next topic. Yes.
Arun, can you please mute the non-speakers? Please mute the non-speakers.
I request Vidya Tobi ma'am to please read CV of Sampath Kumari ma'am.
Yes. It is indeed a pleasure to introduce Dr. Sampath Kumari. She is a past vice president of Foxy and my dear friend. She has guided me in many ways in Foxy. At present, she is a secretary of TNFOG and she is doing extremely well, I must say. She has trained many paramedical staff as well as so many people. So,
thank you, Vidya.
I want her to deliver her talk.
Yes.
Definitely.
Vanakkam, Dr. Sampath.
Vanakkam. I am also learning.
Thank you, Dr. Bharati, Dr. Rashri, Dr. Shobha, and Dr. Vidya for this entire opportunity. And the chief guest, Dr. Kunjumoidin, and our guest of honor, Dr. Suman Sinha and Mitra Saxena, and all the faculties and the delegates. I'll share my screen. Hope it is visible.
Yes, madam. It's not full screen, madam, but it is visible.
It will come, what happened?
Slideshow. Yes, it is there.
Thank you, Vidya. So I am expecting Vidya and Bharati in August 3rd in Chennai. Welcome.
Yes.
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 So the topic given to me is iron deficiency anemia, IDA. See, if all of us are seeing at least 1 or 2 cases daily with these cases. Iron deficiency anemia is the most common nutritional deficiency globally, affecting 1.2 billion people, and is the leading cause of anemia. Prevalence of anemia in pregnant women is more than 40%. As per WHO, 45.7% of the pregnant women in urban areas and 52.1% in the rural areas are having the hemoglobin less than 11. As per guidelines, if it is less than 11, 10.9, we consider as anemia. Anemia in pregnancy has been associated with increased maternal mortality and postpartum hemorrhage risk. Directly or indirectly, about 40 to 50% of maternal mortality is due to anemia. So CDC defines anemia as in pregnancy as hemoglobin less than 11 grams in the first and third trimester and less than 10.5 grams in the second trimester, and hematocrit being 33% and 32%. WHO also defines the anemia in pregnancy is less than 11 grams. It can be of 3, mild, moderate, and severe, 9 to 10.9 being mild, and 7.8 to 9 being 9, and less than 7 being the severe. In the ICMR, we have the very severe, which is less than 4 grams. IDA, this is having 3 stages. The storage, stage 1 is storage depletion, and stage 2 is mild deficiency, and stage 3 is IDA, where the ferritin is the storage form of iron, as all of us know. The low ferritin level is the first sign that the body's iron stores are compromised. Then the mild deficiency, that is during the second stage of iron deficiency. Transport iron, storage is ferritin and transport is iron transferring, which is decreasing. This is often accomplished by the reduction in size of the RBC, even though hemoglobin level remains normal. And stage 3 is IDA. Hemoglobin level drops to the stage. Accordingly, we divide as mild, moderate, and severe. RBC in few numbers, smaller, and contains less hemoglobin. See, so now the patient is having the hemoglobin. As usual, the patient will come with complaints of dyspnea, pallor, not able to concentrate, palpitation, not able to do the regular household activities. So in these cases, we are going to do the complete blood count. If the hemoglobin is low, it is anemia. The anemia associated with abnormalities, if the platelets, safety means, then if it is not a pregnant case, we go for bone marrow. Bone marrow is not done for the pregnant woman. Abnormalities restricted only to the red cell cells. That is the reticulocyte. Raised means we have to investigate for the hemolytic anemia. Not raised, appropriate to the degree of anemia. Reticulocyte means only the red cell indices. It can be the microcytic anemia, normocytic anemia, and macrocytic anemia. So microcytic, what happens in iron deficiency anemia? It is microcytic. MCV being less than 80. So in this microcytic anemia can also be in thalassemia. So though we do the smear, again we have to go with the investigations of serum ferritin is very, very important. And it is low in iron deficiency anemia, and it is normal in hemoglobin electrophoresis. If it is normal or increased, we think of thalassemia and anemia, chronic disease, sideroblastic. If it is low only, we think of the iron deficiency anemia. So serum ferritin level more than 30 means MCV is less than 80, we go with electrophoresis. More than 90 is B12 and folate. So if serum ferritin is low, it is IDA. If it is increased, other causes. So IDA, low hemoglobin, low packed cell volume, low MCV, low MCH, low MCHC. Microcytosis, hypochromia, that is the hallmark. RDVW, that is the red cell distribution with this increased. Serum ferritin is less than 15 micrograms per DIL. Serum iron is low, total iron binding capacity is increased, and transfer in saturation is less than 10%. Routinely, we will do up to the serum ferritin. If needed, only we are going to do complete hemoglobin, complete hemogram, smear, and the serum ferritin is very, very important. This some in centers, they do. The free erythrocyte protoporphyrin is increased soluble transfer in receptors in serum. In bone marrow, that is not done in the pregnant woman. So how we are going to differentiate iron deficiency, inflammation, thalassemia, and sideroblastic anemia? Smear, micro and hypo, almost everything is having the iron deficiency, thalassemia, inflammation have micro and hypo, sideroblastic, it is variable. Then we come to the serum ferritin. If it is low, less than 15, iron deficiency. If it is more than 30, 50 to 300, thalassemia. 30 to 200 inflammation. Sideroblastic, again, it is like thalassemia. Then compare with the serum iron 30, 50, whatever total iron binding capacity to differentiate it from the other anemia. IDA can be differentiated from thalassemia with the Mendel's insert or index also if you don't have the electrophoresis methods. The average daily requirement of iron has been calculated as 0.8 milligram per day in the first trimester and increases to 7.5 milligram per day in the third trimester. So as the trimester increase, dose is important. The average daily absorption varies from 0.8 to 4.5 milligram, depending on the type of the staple used. The demands is like this. Ambulatory iron loss is 230 milligram, increase in red cell mass 450, newborn baby is 270 milligram, placenta and umbilical cord 90, blood loss at delivery is 200. So total gross is 1002 to 40. Net iron demands is absence of the menstruation. Since they don't have the routine bleeding, there is a storage of 160 milligram, postpartum decrease in red cell mass 450. So this is the demand of the iron. What NHM tells to compensate this demand? The WHO suggests 30 to 60 milligram per day of elemental iron for all pregnant women, whether they are anemic or not. We are going to give the 100 milligram elemental iron with 500 microgram of folic acid, preferably in the last 100 days. So this equivalent 60 milligram elemental iron is 300 milligram of ferrous sulfate heptahydrate or 180 milligram of ferrous fumarate or 500 milligram of ferrous gluconate. Depending on the form, we need only the 60 milligram elemental iron. So this is not given in the first trimester, that is 14 to 16 weeks, because as all of us know, the absorption is in the duodenum. The patient may have the vomiting. So it is started in the early second trimester and after continue or late second trimester and third trimester, preferably 100 days. If the patient is anemic, the dose can be increased and it can be started earlier. Why you want to treat this anemia? If anemia is not treated, what will happen? The antepartum complications, it may go for a preterm delivery. In the first trimester, it can also go for the abortions, premature rupture of the membranes, the preeclampsia. Most of the time, PAH patient will be associated with anemia and intrauterine death and infection, repeated infection. Hemoglobin is reduced, immunity is reduced, the patient will have recurrent UTI, recurrent respiratory infection, fever, and the APH, antepartum hemorrhage, and finally, if the hemoglobin is very less, they can go even for the congestive heart failure. Then the intrapartum complications. If you are going to deliver a patient, the pregnant woman with a hemoglobin of 5 gram, what can happen? Already we are going to lose 300 ml of blood. So these patients can again go for other complications. What are all the intrapartum complications? The patient will not strain, she will be tired, the prolonged labor. And that can be increased rate of operative delivery, induced labor, fetal distress, and abruption. So if the pregnant woman has delivered with 4 grams, definitely there is a complication of postpartum hemorrhage. So postpartum complications, whenever anemia patient is going to get delivered, we should keep ready the PPH kit that immediately the misoprostol, carboprostol, carbitocin, the Amstel method has to be followed. So if the anemia patient should be very, very carefully delivered. Then it can repeated infections. It can go for puerperal sepsis, episiotomy wound may not heal. If it's an LSES, there is again an infections in the scar. So that proper antibiotic and proper care should be taken care. And there should be that can be lactation failure and pulmonary thromboembolism. See, anemia corrected patient, if they are behaving and talking irrelevantly in the postnatal ward, don't think that it can be due to psychosis, puerperal psychosis. Always in case of anemia, we have to think of the embolism. It can be the cerebral embolism. So that is very, very important that the pulmonary thromboembolism feature that can affect the cerebrum and the patient can go for a irrelevant organ. Then the subinvolution of the uterus, postpartum depression. These are all the postpartum complications and the fetal outcome being low birth weight, prematurity, infections again, congenital malformations may be present, not only with the anemia, due to some other cases also with the PAH or IUGR, neonatal anemia, abnormal cognizant development, increased risk of cytopenia. These are all the complications. So anemia has to be corrected before delivery. If you are going to post her for LSES, at least the hemoglobin should be 10 gram before posting the case for the LSES. So the WHO recommends routine deworming. That is, normally we do not know what is happening. So the deworming of albendazole tablet 400 milligram or mebendazole 500 in all patients, preferably in the second trimester, 18 to 20 weeks, in the areas where the both line prevalence of hookworm and trichuria is trichuria. But in the Tamil Nadu government, we are giving for all patients this deworming tablet. This is the Cochrane, which tells if the hemoglobin is less than 11, get the CBC and indices. Whether it is normocytics or microcytic, the smear depends. If nothing is there, it is an IDA. If the hemoglobin is less than 4, significant bleeding or evidence of hemodynamic compromise means it goes to the severe and you have to go for the urgent transfusion. And if everything iron serum ferritin is increased, mean you go with a hemoglobinopathies. If it is only the iron deficiency, what is the treatment? First trimester, second trimester. Always the anemia has to be treated depending on the trimester. If it is in any trimester, if the hemoglobin is less than 4, only blood transfusions. If it is moderate, we can go like this. In the first trimester, 100 to 200 milligram of elemental oral iron. If needed, it can be double and check the hemoglobin after 2 weeks. If good response means continue it for the remaining months. If no response means check the compliance, whether she is taking and whether she is not taking. In that cases, no response means you can go with even the injection type of whatever intravenous sucrose, iron sucrose. Nowadays, it is very available. If it is in the second trimester, if the hemoglobin is more than 7, again the same procedure. If it is less than 7, check the serum ferritin. Depending on the ferritin, think whether it is thalassemia or whether it is iron deficiency anemia. If it is less than 30 means go with the IV iron. Now the iron sucrose is available. Ferritin 30 to 100 with high CRP, this has to be done. And in the third trimester, again, if it is more than 7, check the serum ferritin, rule out the thalassemia and go with the same treatment. If it is less than 7, always better to go with the urgent blood transfusions in the third trimester. At any trimester less than 4 and in the third trimester, if it is less than 7, go with the transfusion. So what are the oral preparations? It depends on the type of the iron preparation. As I told, absorption will be there. The absorption of oral iron increases with the increasing doses of oral iron up to 160 milligram. All pregnant women should be instructed to take this tablet in the empty stomach or 1 hour after meals for better absorption. And it can be taken with the vitamin C, which will, that is with the mix orange juice, which will increase the absorption. And the calcium should not be taken with the oral iron, which will reduce the absorption. This diet, whatever the treatment it is given, the iron-rich diet should be taken by the pregnant woman. Then the Ministry of Health, if the orally, if they are not comfortable, then if they are not taking,
this
then
paper is for what you have been keeping
intravenous
route. No?
Previously, we were giving IM injections. See, this IM injection, sometimes it can be produce rashes and the area of injections and the arthritis will be present. To avoid this painful injection, dark discoloration and the myalgia, arthritis, hypersensitivity, now we have the intravenous route of injections. This intravenous low molecular weight iron dextran, which was given orally with the calculating the iron dose, it was given in the IV infusion. But nowadays it is not given. When it is given in the IM means in the ZIG technique, it was given. In some government hospital setups, the patient, when they are not willing for intravenous route, the iron dextran is given. How are we going to give this intravenous? Intravenous is the advantage, complete bioavailability with fewer GI side effects and faster recovery of the hemoglobin than the oral iron. So the disadvantage is it requires multiple tray infusions. Iron sucrose means which you can give 3 times. Weekly, only 3 times you can give. It has to be given in the multiple infusions. The iron sucrose, how it is administered? The infusion is administered as every 2.5 ml of iron sucrose diluted with the maximum of 100 ml of 0.9% sodium chloride and immediately prior to the infusion. It can be given within 15 minutes. Each ampule is 100 milligram, maximum of 200 milligram. In 200 ml of normal saline, it can be given. And it should be given within in a week, it can at least 3 times you can give. That is 600. Maximum of 600 milligram you can give. Then check the hemoglobin. And then only you can repeat. Otherwise, it is not needed. So IV iron indication is failure to oral therapy, non-compliance, late second and third trimester, malabsorption, bleeding diathesis, in combinations with erythropoietin. Some hospitals, they are using in that combination also. It can be used moderate to severe postpartum anemia. The postpartum hemorrhage, it can be used. Contraindication is lack of facilities. If there is some reactions, the facility should know how to make them collapse. If any hyper anaphylaxis shock is present, they should be in a position to revive. And gestation period less than 12 weeks, it is not given known state of iron overload. So IV infusion, there is no need for the test dose. If you are going to start with the IV iron, the oral iron should be stopped 24 hours and it can be restarted after 4 to 5 days. Serum ferritin is high within 8 weeks. So before giving the IV iron dose, you have to get the consent, and the serum ferritin level also has to be measured to rule out the thalassemia. Intravenous iron is superior to oral iron with respect to faster increase and faster replenishment of the body iron stores, reduces the need of blood transfusion. Many patients are afraid of blood transfusion. So with this IV dose, the number of blood transfusion has been reduced. The other parenteral, see, this is the one which I told, informed consent is important, serum ferritin is important, and the resuscitation facilities should be there before giving an IV infusion. The vitals should be checked periodically during and at the time of the infusion. The next comes the FCM. There are many studies which tells that ferric carboxymaltose can be given in the antenatal period, and we are using. And some hospitals, they are not following because it is not the approved drug. So it is better than the iron sucrose. Why? Because iron sucrose needs multiple transfusion. FCM, the single transfusion is enough. Newer preparations like iron isomaltoside and iron carboxymaltose. Now the iron isomaltoside is also available, but I have never used that. Iron carboxymaltose FCM, we are using 50 milligram per ml. Maximum of 1 gram can be used, which allows larger infusion doses of elemental iron to be administered over a short period of time. So this ferric carboxymaltose infusion prior to delivery significantly increases the hemoglobin level. See, if it is less than 10 gram of hemoglobin, you can give 1000 milligram, depending on the weight of the patient. More than 70 means you can even go to the 1500. So this is given similar like the iron sucrose mixed with the normal saline, and it is given within 10 to 15 minutes. So these are all the studies. This is our Indian studies, which tells that International Journal ferric carboxymaltose boon for the anemic pregnant patients. This is the national study. This is from other Switzerland study. Wherever there are a lot of studies, whether nationally or internationally or within the state, that intravenous iron treatment of pregnancy with the FCM. So it can be used. Most of the time it is used in the postpartum and the HMB cases. In the postpartum, immediately, if the patient is having postpartum hemorrhage and the hemoglobin is less than 7, if the patient is not willing to take the blood transfusion and the blood products is not available, then you can go with this FCM. Increase in reticulocyte hemoglobin content is the earliest marker of response as early as 3 days. Rise in hemoglobin is 1 gram expected at the end of 2 weeks and 2 gram expected at the end of almost 3 weeks, not only in the 4 weeks. Once the hemoglobin is normal, then you can go with the after 3 or 4 days with the oral iron, that is 100 to 200 milligram of iron should be given at least for 3 months. That's the reason in the postpartum, we are advising the patients to take the iron tablets at least for 3 months or 6 months. So the blood transfusions where it is needed, blood transfusion is severe anemia in any trimester, that is pregnant, then moderate anemia in the pregnancy of less than 36 weeks. These are all the same things. If generally, if there is a severe anemia means we go with the transfusions, and if the patient is in the failure means, depending on the degree, the patient should be admitted in the ICU and she should be given packed cell volume. If the platelet is reduced, the blood platelet component has to be given. Depending on the component, the blood component has to be given. Postpartum anemia with signs of the hemorrhage. Though transfusion in pregnancy carries additional risk of RBC alloimmunization and volume overload and fetal hemolytic disease, so during giving the blood transfusion, you should be very careful. Decision of transfusion should be individualized depending on available alternatives of the oral and parenteral iron, present and future risk of hemorrhage, comorbidities like DIC, thrombocytopenia, acuteness of the fall in hemoglobin, and cardiovascular status. This recombinant human erythropoietin, I have never used, but sometimes it is also used in some corporate hospitals, shown to be safe and effective for the rapid corrections of the severe peripartum anemia in conjugations with the IV iron, but particularly in cases with antepartum and postpartum hemorrhage and patients with rare blood groups. So how are we going to, now we have corrected the iron anemia, whether it is first or second or third trimester, severe anemia, blood transfusions, moderate and anemia in second and third trimester, early third trimester, go with IV iron. If it is in the first trimester, go with oral iron. So the first stage, increased use of the regional anesthesia and use of the upright position during delivery. It is better and safe, and cut short the second stage with the outlet forceps and the Amstel active management of the third stage of labor. That is very, very essential. When we were house agency, we used to read, apply the methogen at the delivery of the shoulder itself. Methogen is the indications for anemia complicating pregnancy, and it is contraindicated in PIH and heart disease. Nowadays, methogen is most of the time not used if it is used only in the PPH cases. And if you don't follow the Amstel, what happens? You have to remove the manual removal of the placenta. So the manual removal of placenta and episiotomy lead to heavier blood loss even in the modern obstetrics. See, if the patient is having only 5 grams, if you are going to remove it manually, again with the episiotomy, if you not suture correctly, there may be the hematoma. So this should be very, very careful. And the PPH drugs should be kept ready. Whenever you deliver, it should be delivered preferably in the ICU, and all the PPH drugs, all methods, medical methods, mechanical methods, everything should be kept ready when you are going to deliver. This is the E-motive bundle. Now it is followed: massage uterus, oxytocin drug, tranexamic acid, IV fluids, examination of the genital tract for the trauma, and treatment of the refractory PPH. This E-motive bundle is followed everywhere. This is the Makt Bharat, which is the anemia Ministry of the Health, which they follow it. This has the 6 components to reduce the anemia, and the role of what is the village health nurse and the ASHA workers. They should give the iron supplementation, and they should identify the case earlier, and they should follow up the patient. We have heard from the VHN, they will tell suddenly the patient came and suddenly she developed eclampsia. Similarly, the patient would have been in the first trimester 6 grams hemoglobin. The same 6 grams should not be continued till the 3rd trimester. So the ASHA workers has to follow up the case, and the anemia has to be corrected. Provide appropriate and supportive care for anemia. Counseling is very, very important. If you don't take good diet, what will happen? If you don't correct anemia, what will happen? And the dietary counseling is important. That is agri, poultry and fish, fruits which contains the vitamin C, orange juice, high protein diet, black gram, groundnuts, ragi, whole grains, milk, egg. These are all the diet. These are not so costly. This diet has to be advised to the patient, and the A&M to identify the cases earlier and refer the cases to the institute where all facilities are there. This is the IFA supplementation program, which starts from children, adolescent. When a girl is 12 years, the hemoglobin should be 12 grams. If she is not corrected in the adolescent with this low hemoglobin, she will get married. And with this low hemoglobin, she will get pregnant and she will deliver, and finally postpartum hemorrhage will be present. Always it is better to correct the anemia in the adolescents. That is the reason we are doing the school counseling programs. The other anemias, I think Dr. Arulmodi will be covering, the other being the macrocytic folate deficiency and B12 deficiency. Thalassemia can be differentiated with the serum ferritin, and MMR, as I told, indirectly or directly, anemia is the cause for 50 to 60% of the cases. So the take-home message is anemia should be treated before pregnancy. That is premarital counseling is very, very important. When the girl is 12 years, hemoglobin should be 12 grams. Whenever you go for the, I used to tell, Nichetatam, that is before the marriage. If you have the going for the function, at least give the iron tablet as a gift, such that when they become pregnant, it will be corrected. Iron-rich diet is advised, proper management, oral or and iron, IV iron or transfusion, depending on the trimester and depending on the degree of anemia. Anemia patient should be followed regularly. And if you don't have the facilities, kindly refer to the higher institute, such that we will reduce the MMR maternal mortality rate. So everyone should enjoy the pregnancy and they should not end with the complications. Thank you, Bharati. Once again, I thank the KSOGA for the opportunity and doing a wonderful work. Thank you.
Thank you, Dr. Sampath. That was an elaborate discussion about iron deficiency anemia. And your idea, what I liked was the excellent idea of giving iron tablets and folic acid with the Nishchitartham. I think we should put it into practical use now. Dr. Mitra Saxena is here. So for any engagement we go, or any marriage I go, I think nowadays at least we should take a packet of that, and then people will become more aware. And maybe we can also make a small booklet and give that also along with that.
Yes.
Thank you, Dr. Sampath, for the idea. The good idea. Very good. Over to the chairpersons.
Vidya, madam.
Dr. Vidya.
She's not there, I think.
No, she's there. She's trying to unmute herself.
Okay.
Dr.
Then one,
Rajeshri is there.
all the best for Bharti Rajshekar, whoever has joined the president and secretary. Please vote for her, and the committee chairs. Please
Thank
vote
you.
for Dr. Bharti.
Thank you, Dr.
Yeah,
Sampath.
the whole means there are so many. Dr. Kasturi Donimat is also there. She is also contesting for
Quiz committee.
Yes, madam is contesting for quiz committee. No, yes.
Yeah.
All the best.
Yes. So I think Dr. Sampath Kumari has covered all the aspects of iron deficiency anemia, and some practical tips also she has given. So I just want to know about, we all know that the iron deficiency anemia is very, very common. But when it is not responding to iron, one has to be very much alert, and we have to find out the other other deficiencies as well. In many pockets, even still, we have to screen the thalassemia, and always our Bharti is very much interested in hemoglobinopathies, I know, and she talks on that. So these things are also very prevalent in some parts of our country, and they can be easily preventable if you do proper thalassemia screening also. So anyway, Dr. Arul is there, and we are going to listen to the practical aspects of the management of anemia. And anemia is a very dreaded thing, that it is not, it is just a symptom. We have to find out what are and symptoms and signs, and we have to find out the reasons why the anemia is very much prevalent in our country. And we all know that how much complications are there. So why this is a problem, how to recognize, and what can we do as a doctors? One thing, it was very nice, novel idea to give, but how much they consume really is this one. It is a failure from the government side also. We have done so many anemia, this one means prevention, prophylaxis, everything. But even then it is a failure. Then comes the injectable, and many times injectables from the government supply also fails. I have seen that also. I don't know the reasons, and I have not gone to ask them why it is so, but these are the things. So let us move ahead, and I think Dr. Rajeshri must be having some thoughts in her mind also. I invite her for her comments, and then we proceed further. Thank you.
Thank you, madam. As we all know that more than 50% of the population across the planet is anemic, also in India. Unfortunately, since our MBBS days, we study about anemia, but it continues to remain prevalent due to one of the other reasons. Previously, it was nutritional deficiency. Now it is the lifestyle deficiency and other factors which have contributed and continue to remain. And entire obstetrics can be described by just anemia. And still, we have yet to conquer many things. Sometimes we come across situations wherein, in spite of giving the replacements, or even after giving blood transfusion also, the HB will not rise, very unfortunately. But herein we need to rule out other chronic illnesses, and especially chronic diseases or infections which are very much prevalent in our women, like chronic UTI and tuberculosis, or rheumatoid arthritis, or autoimmune disorders, or all such things which one needs to consider when the patient do not respond to the iron that we are giving. And as rightly pointed out, testing the iron ferritin remains the very strong indicator as to know whether we are really dealing with iron deficiency anemia or not. And thank you so much, madam, for giving a very elaborative talk. And it was very nice that any amount of time we revise ourselves about anemia, it still is incomplete. And thank you so much for the talk. Thank you.
Thank you. Arulmozhi madam, she is the one person with KSOGA and TNFOG.
Yeah.
Yes, madam, welcome.
You are with all the OGs.
It was very excellent talk, Dr. Sampath Kumar madam. It was very nice, very informative.
Yes.
Actually, it's the need of the hour. We know anemia left and right. Every day we are seeing every other patient is anemic, but still something we are not able to eradicate it.
Yes.
That is the worst part of it, and which is easily detectable and easily eradicable, but we're not able to do practically on hand, ground level. So
It is
something has to be done, and it's a very nice topic.
It is keeping the academic platforms alive.
If I may be allowed to say something, thank you,
Yes,
Dr.
please,
Sampath.
Dr.
That was
Mitra.
such a wonderful talk. And as I mentioned, that everybody will give their some nice, interesting tip. So Dr. Sampath's tip was very, innovative. That, we have to raise the awareness level. I have worked in Middle East, and I personally feel that in our country, our dietary habits, majority are vegetarian, and that is one of the reasons that we do not have diet rich in iron. Secondly, the menstrual problems which are plaguing our women. So loss of blood and not enough in the diet. This is something which has made anemia something which is endemic in India. So I personally feel that we know that in Western countries, European countries, America, their diet is very rich in animal proteins, and we know that muscle and all are very rich of myoglobin. So their diet, their way of life, their awareness, and definitely they do not need iron supplementation as our women who are pregnant need. So we have to accept that we have to improve the educational level of our women, that we should not accept anemia as a way of life. So I'm really grateful to you, Dr. Bharati and KSOGA team, that you have given us an opportunity to revise anemia. And I'll be sitting through the panel discussion as well. So thank you
Dr.
so much.
Mitra. Thank you
no,
very much,
thank you.
Dr. Mitra.
Yes,
Thank you, madam. Thank you, Sampath Kumari, madam. It was a wonderful.
Dr. Mitra, madam, what you told is correct. Actually, we don't see this kind of anemia in the Western countries because of their non-vegetarian diet mainly.
Madam, I have a question, Sampath, madam.
Rajshri.
Yes, ma'am, in case the patient is having 13 or 14 gram hemoglobin, do you still think that we should give iron replacement to her or tablets for her?
Supplementation, yes.
Definitely
Supplementation.
during the delivery, they are
Have to.
300 ml. We cannot depend on the lab reports. So better for 100 days, you can give only the 60 milligram. They are
60
going to
milligrams.
get absorbed. You can give.
60 milligram supplemental is essential.
And actually, in our antenatal patients, Dr. Rajshri, we are always
Yes.
doing evaluation of hemoglobin. We never bank on one reading. We understand there's going to be dilutional anemia. So it is quite sensible to watch if she actually develops anemia. Of course, supplement her. But if she is of that kind who maintains 13 grams, I think I always encourage my patients. They're very good, very good. You are saving on the iron karcha. So,
Correct.
any which way, we cannot decrease our vigilance for every pregnant lady in our country. Kab
Yes.
anemic ho jayegi, we don't know. So,
Correct.
we do. Repeatedly,
Also,
we do.
Rajeshwari,
the
even if it is
Shobha,
13,
Shobha,
even if it
please
is
go
13,
ahead
we
with the
need to give
panel. I
iron.
think the answers will be,
Yes.
the questions will be answered by the panel.
Yeah.
Yes.
Okay.
Okay, ma'am. Okay.
Okay. But
Thank
we
you,
need to give
madam.
iron, even if it is 13. Yeah.
Prophylactic iron should be given. When anemia
it's a
is
must.
there, therapeutic iron should be given. Yeah. Thank you very much, Sampath Kumari, madam. That was a very crisp and precise talk, and we learned many things from you. Now we move on to the next session. That is a very interesting panel, which is going to be moderated by Dr. Arul Moli. So I call upon the chairpersons for this panel, Dr. Durgadas sir and Dr. Kasturi Donimat madam. As Durgadas sir is not able to join today, I think Kasturi madam should take all the responsibility.
I think
No,
Dr.
we have
Dr.
Dr. Suman, Dr. Mitra, and all of us are there also.
Okay, okay.
To introduce Kasturi madam, she is my
No need, Shobha, no need.
She has been the past president of KSOGA, and she has been a great teacher, and she has trained thousands of students across Karnataka. And now madam is contesting for quiz committee. And she was the HOD of KIMS Medical College. She is the professor in KIMS.
Shobha, bus.
Okay. She has got many achievements.
We'll go ahead with the panel, which is more
Shobha,
interesting.
go ahead with the panel, yes.
Which is more interesting than this.
Okay. Now I call upon Kasturi madam to introduce Dr. Arul Moli madam, who is going to be the moderator of the panel.
Yeah, it's my pleasure. First of all, thanks to Dr. Bharati, Dr. Vidya, for giving me this opportunity. And we had a very nice message from the chief guest, Dr. Koinamuddin and Dr. Suman, Dr. Mitra Saxena. And we just now heard a very excellent lecture from Sampath Kumari madam. So now we have a very dynamic person, Dr. Arul Moji, she's both part of Karnataka and Tamil Nadu. And I just was going through questions prepared by you, madam. Doctor, so just few words about Dr. Arul Moji. She's a consultant at Ramakrishna Medical Center, Trichy, Tamil Nadu, formerly head of the department and postgraduate teacher at Church of South India Hospital, Bangalore, past president of Bangalore's OBGYN Society, editor and chief author, monograph on anemia 2008, severe acute maternal morbidity 2012, and distinguished teacher award, BSOG PG Forum, and lifetime achievement award. It's really a pleasure to have you here, and we always feel you're more of a Karnataka.
She is. She is.
I am. I
Yes,
belong
very much.
Very much you're part of our this thing. So with these few words, I introduce you and looking forward for a very academic discussion. I also welcome all the panelists who are really great luminaries in their field. Dr. Asha Nervi, head of the department of SDM, and my good friend, Dr. Nagrata Kuntoji from Bagalkot, Dr. Shivkumar, Dr. Tamil Selvi, Dr. Lakshmi, and Dr. Ripa Reddy. So we are looking forward for a very excellent and a very academic, in-depth discussion about anemia. Thank you everyone, and welcome you all.
Thank you, Dr. Kasturi ma'am.
Thank you so much, Dr. Kasturi ma'am. And I hope I come up to your expectations.
No, you
It
definitely.
is my
no doubt.
privilege, my pleasure and honor to be on this platform. And thanks to Dr. Vidyathobi and Dr. Bharti Rajshekar for inviting me for this. Shobha, thank you, Kane. You have been updating me frequently on what has been happening on this program without any break. A word of thanks, a special word of thanks to Dr. Tamil, who is from Tamil Nadu, from Trichy, who just over a phone call said yes to it. Hardly 24 hours ago, I asked her, come on to our panel. She said yes. Thank you, Tamil. Okay, shall we move on to the panel?
Yes.
I'm waiting to see the experts. Shall I share screen?
Yes, please, Arul. Please go ahead.
My screen is visible to all.
Yes,
Yes, madam.
Visible, just make it slideshow. Arul.
I will do it. Okay. Yes. So over the next several minutes, we shall go through what Dr. Sampath has already told us. In fact, she's taken off all my points, what I wanted to bring forth. And she's given the panelists a lot of clues to answering. Well, that was quite welcome. It was a nice going through a chapter on anemia. Wonderful. And we also got to know the protocol by the Tamil Nadu government on the management of anemia trimester-wise. That flow chart is a much used one. Okay, we have experts. This platform is really intense with experts. Presidents of societies, HODs, professors. Oh my God. I think all of you will be absolutely just wiping out anemia from your societies and our society. So welcome to all of you. And we shall go right into the panel with the first question going to Dr. Asha. I'm going in the alphabetical order of the panelists' names. So Asha, what percentage of your
Yes, ma'am.
patients?
Yeah. Thank you, ma'am.
What percentage of your pregnant patients are anemic?
Yes, madam. We do have almost 50% are anemic, madam, in our setup, and we do get severe degree of anemia in a patient. If you see 100 patient, at least in that we have 3 to 4 as severe anemia, madam.
Excellent. Any different numbers from others?
Severe
roughly
anemia, not that common because ours is a private institute.
Okay.
But properly, Kasturi ma'am and all their institute, I think they have a lot of anemic patient. But we almost have a mild to moderate 50%. Many are majority more than 50, 60 also I see they are anemic. Around
You are
9.5.
lucky. You're lucky if it's 50%.
Yes.
52 to 94% of our women are anemic, pregnant women. Anemia causes death and disability. Now we will come to death. Now the answer is on the screen because this is a much repeated question, much repeated answer. What I want to stress here is that in India, there are over 300 maternal deaths every day. And about 2/3, that is 200, are due to anemia. And FOGSI says, if you can eradicate anemia, you'll be saving at least 200 mothers every day. Okay. And disability, do you think if they survive, they are fine? Dr. Lakshmi? Dr. Lakshmi is there? Or Dr.
Her
Nagar?
video. We see her there, but I don't know whether she's
Muted or what?
no, maybe she's not on the seat. I think you
Uh,
could pass it on to the next panelist.
Okay, Dr. Nagaratna is there? Tamil?
Yeah, Dr. Nagaratna was there.
Okay, Tamil Shelvi.
Madam, Deepa Reddy is there.
Who's
Hello,
there?
Deepa Reddy.
Okay, Deepa. Sorry, Deepa. Deepa, can you tell me if the woman survives and lives beyond her pregnancy in spite of her anemia, do you think she's fine or she's disabled?
First of all, good evening, everyone, to all my seniors here. I haven't had the opportunity to wish you all in the beginning. And I am very much new to this forum. I'm pretty sure you all participated in hundreds of webinars, but I'm pretty new to this. So I'd like to take a minute to introduce myself. I'm Deepa.
That's why I love you.
Yes.
I am currently working as an assistant professor in KMC Manipal. Thank you, Vidya Madam, Bharti Madam, and all the other seniors here, and Shobha Ma'am for accepting me into this forum. And coming to the question, even despite a woman having a successful pregnancy outcome, if she's had anemia before, it does not necessarily mean that she would have a completely healthy life in the future, because her anemic problem might persist or may even recur later on.
Do you have a word for it? Do you have a particular name for it?
Quality of life.
Yeah,
DALI.
disability adjusted life years. Yes, that is the number of years lost. Number of healthy years lost to any disability or a disease is what we call as DALI. And yes, anemia continues to be one of the predominant contributors to this index in our country.
Very good. Very well said. So it is disability adjusted life years, DALI, and it's a measure of the overall disease burden expressed as a number of years lost due to ill health, disability, or early death. Can the others unmute, please? Mute, please. So
Can you mute the other non-speakers, please?
It's an expression of years of life lost, YLL, and years lived with disability, YLD. So both put together will be DALI. And this is what we are accepting in our society. There are millions of women who live with DALI. We are only looking at those who die. And we are discussing the mortality, morbidity, like that. So DALI for anemia is a much larger figure. It's beyond numbers. Annually, iron deficiency causes the loss of 25 million healthy life years. 25 million healthy life years. Not a joke. Why? Because you need iron in hemoglobin to take oxygen to the tissues. You need iron in myoglobin to help supply oxygen to the muscles, and iron in enzymes to assist in biochemical reactions. So if any of these organ systems are affected, then there's DALI. Okay. The next question, can I address to Dr. Nagaratna? If she's not there, Dr. Shivakumar?
Ma'am.
Okay.
Uh,
What is this public health issue? What do you mean by public health issue?
we are seeing more than 70% of the anemic patient in our outpatient. So it is a public, it's a public health issue. Every alternate woman, every alternate pregnant, every alternate woman, and most of the women are anemic. So public should be aware and preventive measures should be taken so that the problem is solved.
Okay. Now, a public health issue by a WHO definition is when there's a problem with a greater than 5% prevalence, 5% or more prevalent in the population. It is addressed or called a public health issue. So anemia, we know, is more than 40% prevalence. If it is less than 5, it's not a public health problem. Any disease, any problem. If it's 5 to 19.9, it's a mild public health issue. 20 to 39.9 is a moderate issue. And if the prevalence is greater than 40%, it's a severe public health issue. And therefore, anemia qualifies to be a severe public health issue. Coming to the cutoffs, hemoglobin cutoffs, Dr. Tamil Selvi, what would you consider as a serious problem? At what cutoff? You have to unmute yourself. Please unmute yourself.
Good evening to you all, madam. We all say it is a mild, moderate and severe anemia. In pregnancy, 10 to 11 will be mild anemia and 7 to 10 will be moderate anemia. And less than 7, we consider it as a severe anemia, madam.
Absolutely.
But usually most of our patients are in the moderate anemia. 9.59, we get most of our patients, madam.
Absolutely. So that's quite a job on hand. I'm sorry, this moved a little too fast. Okay. Now, when we have to treat anemia, we will look at what parameters, like there are 10 pregnant women in front of you, all anemic. How do you decide on what to treat, how to treat? That question is to Dr. Asha again.
Yes, ma'am. Like we look for what is her gestational age and what is the degree of anemia. And what is her other things also we take into consideration, like what is her education status, what is her social
she may be 10th standard, she may be illiterate, but you have to treat.
Yes, madam. So mainly we take a degree of anemia and gestational age at what she is.
Age, gestational age and degree of anemia matter.
Anemia, yes.
Also comorbid factors.
Oh, yes, madam. That also comorbidities also.
Could be heart failure. Could be a placenta previa sitting there.
Yes, madam. And history of any PV bleeding in the first trimester, second trimester.
Impending or actually happening bleeding. Okay.
Comorbidities is a very important this one.
Yeah. So severity, period of gestation, and comorbidities. Comorbidities will keep our threshold for treatment, particularly with blood transfusion, a little low, and caution with drugs. Period of gestation is important because we need to know how much time we have to correct that anemia and reach her safely to her delivery. Severity matters because depending on severity, we have our pharmacology. What are the options available? All of us know it's oral iron, IV iron, and BRBC transfusion. Is there anything else, Dr. Deepa?
Madam, Dr. Nagratna madam has joined and Dr. Lakshmi is also there, madam.
Okay, Doctor, shall we go? This question is to Dr. Deepa. Any other option available apart from oral, IV, and PRBC?
Okay, these are the most commonly preferred options.
Any other.
Sometimes we may have to supplement patients with erythropoietin in cases of chronic renal disorders because they may not be responding well enough to these measures.
Okay, good. Why? Okay, entire panel open to all. Any other option?
Dietary advice and that is also very important.
Anti-helminths, madam.
I wanted dietary.
Yes, madam.
Very good. Very good.
And anti-helminthic.
Anti-helminthic. Those are
Anti-helminths.
Okay.
Yes,
Folic
yes,
acid
yes.
tablets.
Yeah, we have, but the iron part of it. The iron part of it. The iron part.
Lifestyle, like a lot of lifestyle modification also we should guide them, madam. They do
Yes,
not
all that option. Those are all
different
add-on
options.
additional stuff you have to do. But the pharmacological options are these, and lifestyle options
Add-ons.
mentioned. Yes. Okay. What tests do we ask for? Do you ask for this or anything different? This question goes to
Yes,
Dr.
madam.
Nagaratna. Dr. Nagaratna.
Nagaratna, madam.
Dr. Nagaratna, are you there?
Yeah, yes, madam. Good evening. Good evening.
Good evening. You tell me, will you do hemoglobin, peripheral smear, and CBC, or you'll do anything less or more?
Yeah, these are must investigation, madam. So along with that, we have to do urine routine also, and also we have to go for
Relating
the.
to anemia. Relating to anemia.
Yeah, okay. We should know what are the iron, serum iron concentration, iron binding protein.
1
So
minute.
we may.
Sorry, 1 minute. I'm interrupting. Do you do iron binding capacity, iron profile, etc. for every pregnant woman who's anemic?
No, not for everyone.
That's what I want. We are doing a down-to-earth panel. So what commonly, normally
These are
do?
not indicated actually.
Okay. So we will all agree on hemoglobin smear and CBC, shall we?
Yes, yes, ma'am.
Okay. Okay. So can you all kind of make out anything from these? To say, this is a peripheral smear, right?
Yes, madam. Yes, madam.
Okay, Dr. Shivkumar, can you tell me broadly like what these represent?
First slide is the microcytic picture, madam.
Yeah.
Second slide, we are seeing the macrocytes with macro size of RBC is increased, but they are pale in color.
Macrocytic hypochromic.
Macrocytic hypochromic.
Then?
And multi-lobe neutrophils we are seeing in the third slide.
Okay.
Fourth one I am not able to make out.
Okay,
Is it a
it's
bone marrow?
uncommon. It's aplastic. This
Aplastic.
could be hemolytic also with these special cells here. Okay. This is just to tell ourselves that a peripheral smear is important.
Important.
Okay. When we have the commonest that we see is a mixed type or microcytic hypochromic or sometimes macrocytic hypochromic, right? So the common anemias are iron deficiency and then B12 folic deficiency, macro. Coming to RBC parameters. Now we have all these things. Now, do you get these parameters done for every woman? Dr. Shiv Kumar?
Yes, madam.
For all?
Yes.
Okay. Microcytic hypochromic and she's not responding to iron. What would you do? Would you give her one more trial with a different iron?
We
will
will
answer?
go for Metzer index, madam.
We can go by the index.
Metzer.
Okay. What does that index tell you?
But will distinguish that it is iron deficiency anemia or other hemoglobinopathies.
Other hemoglobinopathies?
Thalassemia.
Only thalassemia.
Thalassemia.
Iron deficiency or thalassemia? Can you tell our guests how you get the index?
By MCV, mean corpuscular volume and.
Okay, we'll go with that. Before we move on to that question, can I ask Dr. Tamil Shelby, what other tests can differentiate between iron deficiency anemia and thalassemia? Special test?
Hemoglobin electrophoresis, madam.
Excellent, Tamil. Nice. So these are the two tests.
So when we suspect it, we can go for that.
Yes, it's
because
not
when the patient is not responding, we definitely go for electrophoresis, madam.
Absolutely, absolutely. Is there something in history that you can elicit and get a hint of thalassemia?
In the siblings,
Yeah, siblings, parents.
anemia in siblings.
Consanguineous
Because
marriage
if the
also.
family is from a thalassemia belt, you could elicit a little
Belt.
detailed history.
Yes, madam. It is the area from which the patient comes.
Yeah.
Gives an idea.
So this is the Menser index. You have mean corpuscular volume in femtoliters divided by RBC count in millions per microliter. And if the index is 13, greater than 13, it could be iron deficiency anemia. If it's less than 13, thalassemia is more likely. And electrophoresis plus Menser index will give us a clue to which is under our care. So you will have to confirm IDA before pushing iron. This is all absolutely common knowledge. Mean corpuscular volume is decreased, so microcytic. Red cell distribution width is increased. What does it indicate, Dr. Asha? Red cell distribution width?
Yeah, I mean, there is a lot of anisocytosis and piculocytosis is happening, which is very peculiar to iron deficiency anemia.
Yes.
That's what has I understood, madam.
Yes. And serum ferritin is obviously decreased to less than 15 micrograms per liter. Now, if I will give you one special test.
Yes, ma'am.
Dr. Nagaratna, has Dr. Lakshmi joined?
Yes, madam, she's there.
Okay, then, Dr. Lakshmi, can you tell me? I'll give you only one test out of the iron profile. Which will you do to tell me that it's iron deficiency anemia?
Serum ferritin, madam.
I disagree. Do all others agree with her?
Peripheral smear.
One special test.
Serum iron also can be done, madam. But serum
No, the thing is to hit at the answer. Serum ferritin is an
inflammatory
substance. So it can be increased when there is some infection, inflammation going in the body.
Yes, madam.
And that can put you in trouble.
Yes, madam.
So
what is the test,
receptor
madam?
levels, yes. Transferrin saturation, transferrin receptor activity, total binding capacity. These are all
yeah.
better
TIBC.
indicators as compared to serum ferritin. Okay.
Yes, madam.
Just to bring out that point, I have added this.
TIBC is quite common. We do it, madam.
Okay, okay. So how do we go about? We are doing a hemoglobin first, at first booking visit. Then if she's not anemic, she could still be iron deficient. This question was raised after Dr. Sampath Kumari's talk. That is, hemoglobin is 12.5 or 13 grams. Would you still give iron supplement? Wasn't that asked? You all were there.
Yes, madam. Yes.
So this is a situation. So, she may not be anemic by definition, but she could be iron deficient. Her stores may be khali. So you still have to give her an iron supplement. And then you have those who are anemic, you have to give them iron therapy. So supplement is 60 milligrams elemental per day. Therapy is 120 to 180. All agree, right?
Yes, madam.
To begin with, we all must treat it as IDA unless it is proved otherwise. So along with the therapeutic, now she is anemic, confirmed. Along with a therapeutic dose of oral iron, you will add, already all said, folic acid, B12 and proteins. You also mentioned about deworming. We'll give albendazole once in pregnancy. That is after 4 completed months. And then you will plug any chronic blood loss. Now I'll just put a halt to the presentation here. I'll ask you, when in pregnancy do you start iron? That is to Dr. Deepa.
Yeah, madam, normally we start at around 14 weeks because in the first trimester they're intolerant due to the associated nausea and vomiting, and also the demand rises to about 6 milligrams per day from after the 8th to 10th week in pregnancy.
She's already anemic. So her maternal demand is already there. What if she bleeds tomorrow and drops her hemoglobin again? You're not waiting for that, no?
In an anemic woman, if we detect anemia in the very first trimester itself, then we may have to consider parenteral iron therapy instead of going for oral iron.
Do you all agree?
In the first trimester, we don't advise
No
either oral or
parenteral
IV.
in the first
Yes.
No
trimester.
parenteral line in
Let
first
us make
trimester.
these points clear because these are what we need to know in practice.
Yes, madam.
Point number 1, oral iron from her diet should be encouraged.
Yes, madam.
Iron
Diet.
food.
Secondly, iron may be given in
Severe
special
anemia.
situations, even in the first trimester, even in the first trimester, particularly late first trimester.
After 11 weeks.
Organogenesis is
Yes, ma'am.
almost through. Okay. And when you choose to give iron in that late first trimester, you will choose a heme iron rather than a non-heme
Elemental iron.
elemental iron. Because heme iron is something like dietary iron.
Yes, madam. Mm.
Okay. So that is permitted. To some extent, you can adjust there. Third point is you will not give IV iron in the first trimester. Because that goes directly into the bloodstream, directly hits wherever it should not. Okay. And there can be iron toxicity and teratogenesis and whatnot. So that point is clear?
Yes, madam.
Okay. So then you said you would start iron at 14 weeks, correct?
Yes, madam.
14 weeks. And if vomiting is not yet settled down, so you could even push it to 16 weeks. There's no big hurry. But we'll keep it as 14 to 16 weeks. And what do you give? How much do you give? Dr. Deepa?
Yeah, in a woman with existing anemia, we would have to give therapeutic dose, ma'am, which is about 120 milligrams to 200 milligrams per day.
How will you give? You are having.
So if we are giving a
60
tablet which has 100
tablets.
mg elemental iron, we can make that BD, and if it's a tablet with 60, then we can ask her to take that as TID dose.
When will she take in respect to
Yeah,
her?
and ideally, iron tablets are advised to be taken in an empty stomach for better absorption. But if that is not possible, then preferably 1 to 2 hours before a meal, and not to be combined with tea, coffee, and phytates, phosphates, foods rich in these substances, and also to space her iron supplements from
Agreed.
calcium supplements.
Good job. And she's taking. Then how do you know she's taking? How do you know she's responding?
Normally we can estimate our reticulocyte counts, which is the first parameter to rise in about 10 days. But symptoms wise, if we were to ask if a lady is taking iron and
No, I want to know what you're doing in your clinic.
We normally estimate after 3 weeks, madam, hemoglobin.
After 3 weeks.
And see for a rise, yeah.
What do you expect?
We rise about at least 2 grams rise.
Great. Dr. Lakshmi. Dr. Lakshmi,
Yes,
are you
madam.
also as lucky as Deepa?
Madam, we will repeat our HB after 15 days. At least there should be rise of hemoglobin by about 1 gram.
Yeah. See, I put it on screen because it has to be kind of drilled in. You have to give her a therapeutic dose, check hemoglobin after 6 weeks. 6 weeks.
Okay.
And a rise of 1 gram per deciliter is adequate to tell you that things are going well. Normally, you wouldn't call her back in 2 weeks for even her next antenatal visit, no? Lakshmi?
Yes, madam.
So this would be fair enough. Like she'll come to you after a month or so. When she comes at 14 weeks, she's not going to come back at 16 weeks.
Yes, ma'am.
So considering that also, I mean, logistics of calling her back and all, this would be fair enough. And taking iron for 6 weeks is anyway not detrimental to her health. And she'll come back and give you a good rise in hemoglobin. Okay, if it's good, it confirms IDA and you'll continue same therapy. You will do the rest of it. Supposing there is no 1 gram rise in hemoglobin at 6 weeks, what would you do, Dr. Nagratna?
So first we have to confirm, madam, whether she's taking the tablet or not.
Oh, confirm whether she's taking. Okay.
Yeah. because
point.
she may not be taking, she may be intolerant or due to some problem she may not be taking. And even if she's taking, so we may have to find out whether she needs other supplements, whether we have given them or not. Like protein is also needed, folic acid, B12. So that also we have to confirm. And if there's any way she's losing blood, that we have to find out.
Yes, absolutely. That was a complete answer that I expected. Very good. So we will check on whether she's really taking it or she's keeping it aside. And then whether she's absorbing or not, whether she has some irritable bowel syndrome or some gastritis which is preventing her from taking. Or sometimes they are sort of frightened to see dark colored stools after taking iron. And they stop till they meet you again to ask.
They think that they are losing blood there, madam. Looking at the black.
Yes, lots of things they can think. They have big brains. Yeah. Okay. Good. Supposing she's done everything the right way and still it's not rising. What is your next option? Dr. Shivakumar. Okay, Dr. Tamil, 1 gram hemoglobin rise is not happening. What will be your next choice? A different oral iron?
Or different oral iron, I don't know, madam. I don't know. Whether the patient responds to the patient doesn't respond to one form of iron, we may try it for the next 15 days with the other forms, but we have to think about the other causes of the anemia, madam.
Certainly, which means you'll have to put on your thinking cap once again and think why she is not responding. Correct?
Yes, she's not responding.
Okay. Iron therapy in the first trimester, you can give dietary iron. Liposomal iron. Can one of you tell me about this liposomal iron? Who will take the lead?
I know only it is released little later part of the duodenum, madam. That's less side effects, I think. That much I have a knowledge. I'm not a great fan of liposomal.
Yeah, we'll learn a little more about it.
Yes, madam. That will be nice.
The point is that it can be given in the first trimester. That late first trimester, I kept this name as reserve. I mentioned dietary and heme iron earlier. This also can be considered for first trimester treatment. Now, in the second and third trimesters, you have oral and IV iron. And then, of course, to blanket it all, you have blood transfusion wherever there is a crisis at any trimester. Okay?
Yes, madam.
So, choice of oral iron. Now, tell me, what is your choice of oral iron? Each one of you, just one name, starting from Asha.
Yes, ma'am. Ferrous sulfate is my most.
Okay. Deepa? Deepa ji?
Ferrous sulfate.
Okay. Lakshmi?
Ferrous sulfate, madam. Ferrous sulfate.
Okay. Nagratna?
Madam, ferrous sulfate, but even ferrous fumarate is also good.
Yeah, next slide.
Okay. Dr. Shivakumar? Dr. Shivakumar, what is your weapon? Okay. Dr. Tamil Selvi, what would you give?
And sometimes here we also use ferrous ascorbate.
Ferrous sulfate, madam, but we have many molecules nowadays. Ferrous ascorbate, ferrous bisglycinate.
Dr. Damayanti, please mute yourself.
Arun, please mute the
चला
others.
ले रहे हैं सबसे बात सर आ रहे हैं है ना अरे इधर एक कर लो ना उधर कर लो लाइट है ना
Are we okay now?
Yes, ma'am.
So ferrous sulfate, ferrous ascorbate, and carbonyl iron, bisglycinate, these are all hugely promoted. Ferrous sulfate is yours faithfully kind of iron preparation. Remains the standard first-line treatment of IDA because it is generally well tolerated, effective, low cost. But it has iron toxicity issues. So you'll have to keep it away from children. This is a real point with ferrous sulfate because they are like these small toffees. sweets and red in color. They're
Like
very
gems.
attractive. And they
They
can
look like gems.
gems.
Yes, yes, madam. Gems.
Yeah.
True, true.
So if they pop in some 10 or 20 gems inside, and some of these could be sugar coated, so they enjoy it, they can end up with iron toxicity. Okay. Ferrous ascorbate is better because it has that vitamin C in it. Carbonyl iron and bisglycinate claim better availability, tolerability, safety, etc. There are innumerable forms of iron, but what I want to say is, if they are very well tolerated, probably they just pass through the canal unabsorbed. That could also be a possibility. Okay, poor response. Why? We have talked much about this. How do you overcome the same? Now, iron, oral iron is not reaching the destination because it's passed out in the fecal matter and much less reaches the bone marrow. Okay. There itself, it will go into the shelf or it will go into trash. Or if it is consumed, very little goes to bone marrow and much goes to the fecal waste. Why? Iron absorption is regulated. That is the reason this is happening. If there's too much iron, the binding capacity of transferrin is exceeded and iron gets deposited in tissues. There's free radical damage happening and there could be tissue and organ damage. So iron is quite toxic, quite toxic. If there's too little iron, of course, we have anemia. This is regulated by what? Shall we go in the reverse?
Yes.
Hepcidin.
Iron absorption is when it is a too much iron, madam, it is deposited in the tissues and
yeah,
because of that we have free radical damage, madam.
Yeah, that is what regulates it. How is that we don't see people with this damage?
Hepcidin.
Yes, you're right. You're right. So hepcidin is what is the regulating molecule. Now, what is hepcidin? Hepcidin is a product from our liver.
Liver, yes, madam.
Okay. If there is, if there's too much iron, there is iron toxicity. If there's iron deficiency, too much hepcidin. Hepcidin actually cuts out absorption of iron. And this hepcidin rises whenever there is inflammation, infection, chronic diseases, cancers, etc. So that's the cause for anemia of chronic diseases and anemia of inflammation. Then in hereditary hemochromatosis, iron overloading and toxicity happens because there's too much iron. Okay, so this balance is maintained by hepcidin. So if there's hepcidin which comes from the liver, it's a security check for iron overload, hepatic regulatory bactericidal protein. It limits transfer of iron from gut cells to the blood, and the absorbed iron gets lost in stool when the cells are shed. So that's why it goes off in the fecal matter. Systemic inflammation leads to increased production of hepcidin, and it blocks iron in gut cells, traps iron in macrophages and liver cells. Everywhere, it puts off one security check. And so that iron cannot be utilized. How can we now get that iron into the system? We'll have to overcome this, no? Because every woman has some infection, inflammation. We can't wait for all that to subside and then give iron and then that should get absorbed, etc. So this is where it acts. We'll skip this slide. We have these special ions which can outsmart hepcidin. This is where I said we'll talk about liposomal or sucrosomal ion. These are the smart ions. Now, can I ask any of the panelists to give me some details? Yes. Okay, shall we go ahead?
Yes, madam, go ahead.
Okay, studies have shown that sucrosomal ion is a new generation ion for improving oral supplementation and liposomal ion for iron deficiency anemia in women of reproductive age. So the literature is for it. What are these? These are actually ferric pyrophosphate. Inside is ferric pyrophosphate. It is protected by a phospholipid layer, a membrane, plus a sucrester matrix called sucrosome. It is packaged differently because small micronization is happening in its production, and micro encapsulation. So there's particle size is small, but the surface area is more. Therefore, there is increase in the absorption with efficacy. What are the advantages? There's better compliance, minimal side effects, and safety is established. It is a targeted delivery to the small intestine.
Small intestine.
It has higher bioavailability because more of it is absorbed with the larger surface. There's no chelation with other metals. So you needn't worry about giving it away from calcium, giving it away from this, that, and whatnot, like in ferrous sulfate. There's no oxidative damage to intestinal epithelium, as may happen with the regular ions. There's a quicker and better response. Now, how is this absorbed and how is it different? This is where the point is. Now, these are not absorbed in the duodenum and jejunum just like our usual ions, but these are absorbed through special cells called the microfold or M cells in the lymphatic system, Peyer's patches of the small intestine. It is by endocytosis, simple absorption, diffusion, fusion of the lipid layer to the plasma membrane with release of contents into the cytoplasm, exchange of lipids between the two layers, and so on. So there is no protein-mediated or enzyme-mediated transport, and therefore there is better bioavailability. So the unique pharmacokinetics and the excellent GI tolerance and higher bioavailability make it function like an orally administered drug, which goes through the lymphatic system and directly into the bloodstream and bypasses hepcidin. Okay?
Yes, madam.
So there's a further plus point. See, we are worried about hepcidin, right?
Yes.
Normal iron salts, as soon as we push in some iron, hepcidin pushes its antenna up. Normal iron salts induce hepcidin upregulation by the absorbed iron stimulating the periportal hepatocytes. Make more hepcidin. There's so much iron coming in. The invasion ಆಗ್ತಿದೆ ಬನ್ನಿ ಅನ್ನೋ ತರ. The liver is asked to make more hepcidin. Then the unabsorbed iron triggers the inflammatory response on the intestinal mucosa and induces hepcidin production. So as soon as you give iron, normal iron salts, hepcidin comes up and less iron is absorbed because of that. Whereas this upregulation is not happening with sucrosomal ion, because sucrosomal ion is not released to the portal bloodstream to hit the liver.
Dr. Archana, please mute yourself.
But into the lymphatic circulation and later the arterial circulation. It doesn't go through the normal channels. It's quite a bypass. So the iron in SI, that is sucrosomal ion, does not interact with the duodenal mucosa as it is protected by sucrosome, and it has also been suggested that the phospholipid layer carriers may exert anti-inflammatory properties and therefore more iron is absorbed. So these are all different ways and mechanisms by which these ions appear to act better. So one suggestion for practice is that if the normal usual routine ions are not giving a good response, you may try a different oral ion, and this is what I meant by that. You could give heme ion. You could give one of these ions. Okay, safety is proven. You need only about 28 to 30 milligrams a day of this ion. See, this is 30 milligrams a day is enough, or sucrosomal 14 milligrams a day, sucrosomal 28 milligrams. This was in a study. And certainly 28 milligrams a day. These preparations are available in the market. Then we did talk about the hemoglobin rise. Day 14 hemoglobin, this is from a research paper for defining our response in. So what answer I got as checking at 15 days is also correct, but only for our logistic reasons, I said 6 weeks check of hemoglobin is better. So if that's not happening, you could choose an IV iron. Coming to IV iron, we have two formulations, iron sucrose and ferric carboxy maltose. You have advantages with each of these. Iron sucrose, I think, is given by the government and it's free of cost. But I think FCM is yet to come into the government institutions. Am I right? Do correct me if I'm wrong.
Yes, madam.
Yes, ma'am.
Madam, I am from government institute, but we are having FCM injections, madam. We are having regular supply of FCM injections.
That is really excellent.
great.
So,
Dr. Arul, the new Government of India guidelines, they have introduced FCM into the protocol.
yeah, is it available in the institution?
Yes.
Yes, madam, we are
yes.
having regular supply of FCM
started.
injections.
Very nice. That's really nice because where I'm working, I have seen only iron sucrose being given in the government institution.
No, now it is
Therefore,
recently.
I'm unaware of this.
Just recently it has been added.
Okay, probably it's on its way here too.
Yes.
So there are advantages.
Yeah.
There are advantages with FCM. So what is your choice of IV iron and when do you advise? Well, we kind of can muster this. So this has been approved, IV iron sucrose, and we've been using. FCM also has been approved and we are using. Dose calculation is everybody's knowledge. It's just that simple formula which we are aware of. And what we have to be clear about is, do you give a test dose? Now, who in the panel, rather in whose hospital in the panel do you give a test dose? Anybody?
No, madam, we do not
No,
give.
no. That means it's a wonderful message.
Yes,
no
madam.
test dose required. No test dose required.
Only initially we started little slow, but after 5 minutes we increased the trip rate, madam. That's
Why?
That's what we follow, thinking that.
That's why this panel.
Yes, madam. We
You
thought
can actually give a direct IV push also.
Yes, madam. That is
Then
also there.
where does the slow and fast come there? Huh?
No,
I mean,
just
if you have some myths in your mind, I think you'll have to have it clear, right? Okay. Do you give it in your clinic or in a hospital?
In a hospital setting, madam. We never give it in OPD.
Why?
Because some reports of a severe anaphylactic reaction, they pop
Even though reactions are rare, you'll have to be prepared to face one,
yes.
because this is
Oxygen,
an intervention. I mean, it should not become an error or a crash of commission because you are giving it.
Yes, madam.
You can never come down on safety, isn't it? So
Yes,
you be prepared to face an event. That's all.
Yes.
What are the prerequisites? Of course, it's just no test dose. You can make sure she's not allergic to iron, etc. And there's no infection in the area where you're going to poke her, right?
Yes. Do take consent, madam. I just wanted to know what you people. We have a habit of taking consent for before starting IV iron. It's kind of
anybody
routine
else
in our
also takes consent in the panel? No one else seems to be taking consent.
Dr. Suman Arul, Dr. Suman and Dr. Kasturi Donimat are experts.
Yes, madam. I think that's
so. You
maybe
can ask them.
But we have not taken consent while giving iron sucrose.
Okay.
But of course, with FCM, we have to because it is a very costly drug. So if something goes wrong, some anaphylaxis occur, so they will say कि आपने बताया नहीं, आपने इतना महंगा ड्रग दे दिया.
महंगा ड्रग नहीं, अभी तो फ्री मिल रहा है ना.
हमारे प्राइवेट की बात कर रही हूँ मैडम.
हमारे में मिल रहा है बोल रहे ना. Anyway, cost is. Dr. Suman, just this was by the way.
Yes, madam.
It's not just because of the cost.
Probably there, madam.
Fear of reaction.
Fear
of reaction. But then we give so many drugs in our practice. What about the IV antibiotics? What about so many drugs? For each drug, we don't take a
But
separate.
here there is no test dose, na? So maybe for the IV we do test dose.
Okay, I mean, it's just for my knowledge. Is there any professional body that says that you must take a consent? Like
Not
what
yet.
does Foxy
Not
say?
yet. Not
I
yet.
don't think so, Dr. Arul.
We are not taking consent.
We are
Actually,
not
we do
taking
so many
consent.
these things, but
Okay,
we are
we'll,
not
not
we'll
necessary.
probably find out
left and right every
if,
day. We are
if
doing.
Foxy
We are
would
not taking
recommend
consent.
that.
I think it's an implied consent when we advise them and they accept their treatment.
That's how we've been
We
working.
just
Yeah.
explain them that this is we are giving, and in case they may have something reaction and all, because we have faced some serious reactions, some few
We have
patients.
faced, therefore I told.
Yeah. But we are not into the practice of taking consent.
Okay. Okay. I mean, a point for giving more thought. Thank you. So it can be given undiluted or as an infusion. We are aware of this. Shall we go a little faster?
Yes, ma'am.
Because we have only another 8 minutes. Okay. So FCM is safe.
Yes, madam.
And FCM during pregnancy. It is safe when it's given in the 2nd and 3rd trimester. That's when people come to us mostly. 500 or 1000 may be given. It improves the iron status in 2 weeks to safe levels. It reduces maternal morbidity and avoids blood transfusion. Avoids mortality, gives a better iron status to the newborn. Okay. Now, almost 30% of women who were not previously anemic during pregnancy become anemic after delivery. That means pregnancy promotes a woman to become anemic with all the losses happening. So you should build up. Even if her hemoglobin is 10 or 11, you should fill up the rest of her bowl. What are the cautions? You should avoid in the 1st trimester because it can cross the placental tissue, and use during pregnancy may affect skeletal development in the fetus because it causes a transient, unexplained hypophosphatemia at 2 weeks after injection. So this is the reason why FDA even delayed its okay for use in pregnancy. Of course, it has come through. And also reason not before 16 weeks of pregnancy. You avoid in the presence of acute infection because that iron may serve as a growth factor for bacteria, inhibit phagocytosis, and increase oxidative stress. And avoid in those who are allergic. Response, a feeling of wellness. Why does it happen within 3 or 4 days? Because the biochemistry is improved. The enzyme systems are happy with the inflow of iron. So functions improve and there's a feeling of wellness. Reticulocytosis in 5 to 7 days. Hemoglobin rise in 10 to 12 days and ongoing. Improvement in red cell indices in 10 to 12 days. Now, have you heard of this, or you must have come across complaints? Something called as the restless leg syndrome. This is common in pregnant women. It's one sort of an irresistible urge to move the legs. Okay, and this can be cured by a single dose of FCM, is what the study says. You have adverse effects which will come when you exceed the allowed dose of FCM, and in not following the recommended rate of infusion. Should be at that 15 to 30 minutes time frame. You should follow the same dilution. You should not use anything other than the allowed diluent, which is normal saline.
Normal saline.
Of course, you will avoid in asthma and allergies, and not following the recommended storage conditions also affect it. No refrigeration or freezing. Is it expensive for our women? Let's for a minute think that it is expensive. It's not given free from the government. We did a study on this, and we had 2 arms, one receiving 500, one receiving 1000 milligrams of IV FCM for postpartum women. The response was comparable. So 500 milligram dosage was not inferior. It was a non-inferiority study. of a 500 milligram versus 1000 milligram single dose. Okay. So a single dose of 500 appeared to be safe, efficacious, and cost effective for postpartum anemia. This was our study.
How Friday I think but
Okay. Now IV iron
no.
refused.
Classes.
Okay. IV iron, the woman is refusing. She can't come, she can't take. Ferrous sulfate IFA tablets are not tolerated. What else can be as efficient as IV iron? Anything? Okay. There is one more preparation called ferric maltol. This is the latest entrant into the iron basket, and it is a non-salt formulation. Salt means it is at acid-base crystallization, salt, etc. chemistry. There's something called as a non-salt formulation, and this is one such preparation. It dissociates upon uptake from GI tract, allows iron and maltol to go far to be absorbed separately. And it is not absorbed systemically as an intact complex. So the fetus exposure is unlikely. This is as good as IV iron. It is FDA approved, 30 milligrams twice a day orally for 12 weeks. That's all. 30 milligrams twice a day orally for 12 weeks on an empty stomach. Analysis from phase 3B trials showed oral ferric maltol to be non-inferior to IV ferric carboxymaltose in patients with inflammatory bowel disease because they cannot absorb the usual ions. So even in these people, maltol seemed to work as good as well as IV iron. So we can give iron in the second and third trimesters, but what about first trimester? This is the end of the story. So one quick run through first trimester management. Any thoughts? Okay.
Dietary advice, madam.
Yeah. What diet are you going to tell her that's not said so far?
Yes, madam. She should take a lot of nuts, jaggery, and egg also is rich in iron. Green leafy vegetables. When our so many varieties are dal,
poultry meat,
poultry meat. Yes, hyperemesis. Yes, madam. That's also.
So you have all these things. Diet advice, tablets, blood transfusion, deworming. They want to have an MTP because it's terrible. IV iron, other tablets, investigations refer all these options. But what else can be there? You say give her an iron-rich diet, leafy vegetables, etc. But do you know that green leafy vegetables have lots of phthalates?
Yes, ma'am.
Will inhibit iron absorption. So you'll have to take care of that. Some iron tonic. Iron I'd like to avoid till she crosses 3 months. This is our usual statement. She must get it from her food. There is a novel way to get it from her food. Anybody, any clue?
Cook in iron vessels. Take
Yes.
The vitamin C rich food.
Yes. Okay. To make it a little attractive, there's something called the lucky iron fish, which is made from scrap metal. Okay. And this is just a product. You must have come across this. It is put in the boiling water, removed, and that water is used to cook the meal, and the entire family is benefited. There is no gender bias. Mother also gets the same iron, right? Then, of course, other things, red meat, organ meat, and soups, drumstick, jaggery, groundnuts, sprouts, etc. Cooking in iron vessels. Okay. And heme iron preparations can be given. Other things which you will do will be adding proteins, vitamins, and micros, deworming, arresting ongoing blood loss, GI tract worms. How many worms do you need to make her anemic? 40, 50, 60, 100.
Even one worm is enough, madam.
No, it won't make her anemic. You need at least 40 worms. Okay. Okay, last, coming to blood transfusion. It is an organ transplant. So what are the indications now? One indication you all tell me. Start with Asha.
Yes, madam. If hemoglobin
One indication.
hemoglobin is less than 6 gram in any trimester. I think that's-
Okay, next, Deepa.
Anemia causing failure.
Okay, next,
Anemia
Lakshmi.
cause failure.
Blood loss, acute blood loss, madam.
Yes.
Whenever
Super,
there is
Nagaratna.
Very.
Madam, when it is near term, when it is near our EDD,
Near an EDD, what is what?
we have to go for blood transfusion.
Yeah, when the hemoglobin is how much?
Hello.
Yeah. Okay.
Less than 8.
Less than 7, less than 8?
Less than 8.
Yeah, if it is severe anemia.
Okay. Shivkumar Ore?
Severe anemia with tachycardia.
Okay. Okay, comorbid. Okay. Tamil?
Acute loss, madam. Acute blood
Acute.
loss.
Excellent, excellent. So we have acute massive blood loss, ongoing blood loss like ruptured ectopic APH, PPH, intraoperative hemorrhagic complication, coagulopathy, HELP syndrome, and hemolysis, severe, very severe anemia with CCF. Okay, less than 34 weeks, 5 to 7 grams. More than 34 weeks, even 7 grams. That is closer to term. So this is just the same thing. It's from FOGSI GCPR. So beyond delivery, she's gone through and delivered. Now you have to give the newborn a good start in life by giving a delayed cord clamping. I hope all of you are practicing delayed cord clamping.
Yes, madam. Yes.
Yes.
Wonderful. AMTSL in the 3rd stage and close monitoring in the 4th stage of labor. All of you, yes?
Yes.
Yes, madam.
Yes, madam.
Okay. Check hemoglobin after delivery.
Yes.
Give
48
that
hours.
postpartum anemia can
FCM.
be treated while she's still in hospital. On after 2 days, check hemoglobin. Give her that 500 milligrams of FCM, one shot. Her IV line also will still be there before discharge.
Yes, madam. Yes,
That will make her a better person, prevent that dally from happening, and she will lead a better life. Okay? And push for exclusive breastfeeding. Lactational amenorrhea saves blood by not giving her periods, and it prevents pregnancy, without which she'll come back to you for an MTP and lose more blood. Silver shines, gold glitters, and iron strengthens. Agree?
Yes, madam. Yes,
Thank
ma'am.
you.
Very nice.
Let's all work to abolish anemia.
Yes, ma'am.
Thank you, all my
Thank you,
panelists,
Arun,
all
ma'am.
my experts,
Thank you, madam.
and the organizers, everybody for this beautiful platform. Thank
Thank
you.
you, Doctor.
Thank you, Arun. Thank you, Arun.
Thank you, madam.
Yeah. Thank you, Dr. Arul.
Dr. Arul.
Yeah.
Welcome.
Dr. Arul, excellent discussion.
Yes, ma'am.
Thank
It
you.
was very very practical. Very
Yes.
practical, and then very lots of take-home messages. And you made it very interesting also. Actually, anemia is a very day-to-day topic, but you made it so much interesting. And thanks to all the panelists who have done a very good job, and they have put even lots of inputs. Actually, it was something very excellent take-home basis, which you can implement in your day-to-day practice. So thanks to Dr. Arul once again and all the panelists. Yeah.
Thank you, everyone. Thank you, Bharti.
Thank you, everyone.
Excellent, Arul.
Excellent, excellent.
It was a mesmerizing panel and so many interesting tips, and your slides were, I would say,
Very nice, ma'am.
I have no words to explain. Excellent
Yes.
question. Put up very well. Put up very well.
Yeah.
Bharti madam, can I say?
And thank you. And she accepted on the 11th hour. Within the minutes, Dr. Arul said yes. And I very well knew that as a BSOG president, she had released one anemia booklet. Still, I have that booklet
Oh,
on anemia.
okay.
Yes.
Madam,
Shobha also has done a very good
He
job.
remembers that. Yeah.
can I say
So
something?
that was
Yes,
very
Rajeshri,
good.
please
And
put on your
yeah.
video.
Yeah,
We request all the participants and panelists to kindly put on their videos so that we can have a good photograph.
Madam, about 15 years back, I was one of the panelists in Arul Moi's madam's moderation. Even today, she carries the same kind of passion, same kind of teaching, and same kind of interest.
Yeah,
Whatever she deliberates.
Dedicated teacher.
I was very fortunate.
Dedicated teacher.
Yes, I was very fortunate to be in one of the programs of BSOG long back, wherein Madam was president.
Yeah.
And, I was a panelist, and thank you so much for bringing back those, nostalgic memories and wonderful deliberation. Thank you so much. And nice to see you on the platform after such long time.
Thank you, Rajshri. Thank you so much.
Thank you.
Thank you. Thank you.
Thanks to everyone. Yeah.
So Shobha, you can
Thank
take
you.
the photograph, and if any questions from the audience or any comments from the
Check the
audience, I
chat
think we
box
can take
also.
for 2 minutes.
Yeah, just one this thing. What we are seeing here, this anemia in our part of this thing is some geographical variation. You know what? Some patients coming from a particular geographic area are especially very anemic. And not only anemia, we are seeing not just anemia, they are coming with pancytopenia and some with thrombocytopenia. You know, nowadays it's quite increased, and we are seeing it more increased now after COVID. We are not able to explain, especially this thrombocytopenia. I haven't explained. It's not just gestational thrombocytopenia. Something else is going on. Then very, very less this thing. So especially from some particular, if that patient, if she's 2 grams, then I'll ask them immediately, is she from that geographical area? So we have to find out, do research and find out what is happening in those geographical area, what is their food, what is the type of cooking, or what chemicals they are using to grow the vegetables, something. So I think lots of research needs to be done on this anemia. Yes.
True, very well analyzed, Dr. Kasturi ma'am.
Yeah.
I think, especially with the pesticides and the lead and arsenic and all being used in the.
What about Ranchi? That side, Dr. Suman?
Ranchi,
in your area,
we have sickle cell anemia more, iron deficiency not much,
what is the
but we have more sickle cell anemia.
You have
the tribal belt, I think there's a lot of the
there are
tribal
some
belt of
where
Bihar and Ranchi, they have a lot of, that is why the government of India has taken up the sickle cell elimination project this year, and they have allocated a lot of budget, and they are advising premarital analysis of hemoglobin before they get married, so that they can eliminate the intergenerational transfer of sickle cell disease.
Some particular geographical area,
particular geographical area.
ಕಷ್ಟ ಆಗತ್ತೆ. ಭಾರತಿ ಸಿಕ್ಕಲ್ ಸೆಲ್ ಟ್ರೇಟ್ ಇದೆ, ಡಿಸೀಸ್ ಇದೆ ಅಂದ್ರೆ ಮದುವೆ ಆಗೋದೇ ಕಷ್ಟ ಆಗ್ಬಿಡುತ್ತೆ.
ಇಲ್ಲ, not that. What they have done is, Arul, they have 2 colored cards. So those who are having trait are given a yellow ID card. Those who are not having it are having a white card. So they are advising the youngsters not to marry somebody who has a yellow card, because that means both of them are have the trait, and the child may get affected. So they're educating them on that.
One of the common food habits or intake is the intake of tea, coffee, which will prevent the absorption from the food, and
even betel nut, I think. And lot of them also try to mix the iron preparation. They say tonic na hal jote tagobekada. They have this habit of taking it with milk also.
And food, yes.
Somebody was Dr. Arun. Dr. Arun?
Can I ask ma'am one question?
Arun was Dr. Arun?
Yes.
Just one. Yes. On this thing. See, there is something which some people are coming up like, if you give IV iron, for 1 month, no need to give oral iron.
Yes.
I don't agree with that. Do you all agree with that?
No. But Madam, Dr. Kasturi, the guidelines are saying that.
No, but I don't agree practically with that.
I'll tell you what.
At least 10 days.
Studies have said that continuous iron kodo badlu, if you give intermittently, the absorption is better.
Yes.
Studies have said that. Therefore, that is why that is the basic principle in WIFS, weekly iron supplementation for adolescents. So that is
after giving oral for FCM, IV iron, do you restrict them from taking oral iron for a month?
10 days. Yes. We restrict for 10 days.
Short days is okay, but for long period that time.
No, for 10 days. After that, ಅಲ್ಲಿ FCM ನಿಲ್ಲೋದಿಲ್ಲ, half life ಹೊರಟೋಗುತ್ತಲ್ಲ ಎಲ್ಲ.
ಹೌದು, ಅದಕ್ಕೆ ನಾನು ಹೇಳೋದು ಅಷ್ಟು ಲಾಂಗ್ ಪೀರಿಯಡ್ need not stop ಅಂತ ಹೇಳಿ.
Madam, I was talking to Dr. Bella the last 2 days back, and he has given me some references where, according to the study he is doing, they are not repeating any type of iron after the full dose of FCM. So they are calculating the total dose and using the total dose, and then following that 3 months no oral iron.
ಅದೇ ಹೇಳುದು ನಾನು ಲಾಂಗ್ ಪೀರಿಯಡ್ ಕೊಡ್ಬೇಡ ಅಂತಾರೆ 2-3 months
ಅವ್ರ ಸ್ಟಡಿನಲ್ಲಿ ಅದೇ ತಗೊಂಡ್ರದ್ ಮೇಡಮ್ ಅವರು.
ಅದಕ್ಕೆ ಲಾಟ್ಸ್ ಆಫ್ ಲಿಟರೇಚರ್ ಇಸ್ ನೀಡೆಡ್.
Madam, I want to tell one thing. Even in our college was also part of that study. But during that study, we had lot of problems with that study group. But once the study is over, the anemia incidence has come down in our center actually.
Good,
very good. My response, let me here we give a gap of 10 days after an IV injection. But then we are not giving the total required dose as Bharti mentioned.
Please mute yourself, Dr. Vibha Singh. Dr. Vibha, please mute yourself.
Arun, please mute others. Yeah.
Okay, so in our center, we stop oral iron for about 10 days or till her next visit when we give her FCM. That is because we give a standard dose of 500 or 750 as one shot and then ask her to continue with oral iron. We are not doing the full total dose calculation and providing the entire requirement to her. This is a sort of a shortcut to one uniform protocol that we have developed for our regular practice. Otherwise, the cost goes up. Then there's a difference between I had spent so much on FCM, you have spent so much on FCM, etc. So we give one uniform dose, but we continue oral after that gap of 10 days.
I am following the same schedule, Dr. Arul. I also do the same thing.
You need maintenance dose later. See,
after 10 days,
you need maintenance dose, no, later.
Madam, after 10 days, we start them on oral iron. After 10 days,
after
we
10 days
restart
is
on
okay.
oral iron.
But if you totally stop for 2-3 months, then again...
That is if you have given the total
dose.
You know, it's already put in the bank.
If you have already given the total dose, then you can stop.
Yeah, you can stop.
Just given one shot of 700 or
routine, we are not giving total dose, no? We are giving one shot and then...
it takes away that business of calculating everybody's required dose, etc. Just making things a little easy.
Yeah.
And acceptable.
Ma'am, what's the best time to give the oral iron, ma'am? It's been told in the morning. Morning is the best time to be given.
Well, any time away from a meal, away from other salts, other metals, thyroid, whatever. All these are acceptable, away from coffee, tea. So morning is fine.
So Rachna, I generally tell them to take it around 11 a.m. because they would have had their breakfast at 8:30 and their lunch is going to be at 1:30. So I say take it at 11 a.m. Take it with a glass of lime juice or water. I specifically tell them that and send them.
That's a good
yes, ma'am. That's what even I'm following.
Yes, even we follow that.
Yeah.
And you have to insist on that, not taking
and then I have heard that ma'am, there has been a study that the injection FCM does not improve the iron stores. It just improves the hemoglobin but does not improve the stores. Is that true?
No. The studies are there that it does improve the stores.
Thank you, ma'am.
All right.
Thank you, Arun Madam. That was a wonderful panel and a wonderful discussion and sharing of lot of inputs from all the stalwarts of KSOGA and all the societies, and also the delegates share their inputs. I think it's been,
I told you, I have such an intense panel of experts that I was feeling heavy. Certainly, everybody has contributed. Thank you.
But we learned a lot from your slides, madam. There were so many
So
new
I
things
just
to learn from you.
want to know where is this
exhaustive slide anemia.
Yeah, exhaustive
Anemia
slides and
very
exhaustive reading also. I want to know where is
Yeah.
this lucky fish available.
We'll make one.
Yeah, why go behind that fish? Any old iron scrap metal.
Dr. Vidya, I can make a fish and send it to you. I will get it designed tomorrow for you. You want a fish or you want something else?
Vegetarian fish.
So you are vegetarians. I will make it like a carrot or maybe like a tomato and send it.
Madam, you can use
Correct.
any piece of iron in water and use it for boiling, madam. That also helps.
Dr.
Now I
Vidya,
call
it
upon
got
Very
Dr.
nice, no? Putting a fish in water is better than putting small pieces of iron.
Yes,
It
yes.
started in Cambodia.
No, fish
That's
also is
that's
good, Dr.
what.
Vidya. It has a lot of omega fatty acids.
Yeah.
So one iron fish and one regular fish is good for you.
Regular fish to be eaten.
ವಿದ್ಯಾ ಇವತ್ತು ಭಾರತ ನಿಮ್ ಫಿಶ್
Prevents the preterm birth also. Yes, thank you. Thank you.
Thank you.
Now I call upon Dr.
Thank you.
Rachna to give vote of
Thank you,
thanks.
everyone.
Thank you.
Yeah, it's a great honor for me to render the vote of thanks. Firstly, I would like to thank our Chief Patron MG Remat sir for giving this platform and opportunity. And I thank Dr. Vidyathobi ma'am and Bharti ma'am for starting this KSOGA Gyaan Sangam. It's their brainchild, and I immensely thank you, ma'am, for doing it regularly, continuously for the past 1.5 years. And I thank today's chief guest, Dr. Kunjuma sir, who has been here despite his busy schedule. And I also thank the guests of honor today's program, Dr. Suman Sinha ma'am and Mitra Saxena ma'am. And I thank our beloved secretary, Rajashri Paladi ma'am, for chairing the first session. I thank Dr. Sampath Kumari ma'am for giving us wonderful inputs on iron deficiency anemia. She covered it very well, and I also thank our Vidyathobi ma'am for chairing for the second session, Vidyathobi ma'am and also Rajashri ma'am. I thank Arun Moli ma'am. Ma'am, you have done a very exhaustive panel, and I'm sure all of them have taken many take-home messages today. I thank today's expert, Dr. Kasturi Doni ma'am, for her inputs and from her practice. And today we miss Durga Das sir. He couldn't be here. I thank the panelists of today's program who also gave their inputs from their practice, Dr. Asha Nervi ma'am, Nagratna ma'am, Dr. Shokumar sir, Dr. Tamil Selvi ma'am, Dr. Lakshmi and Dr. Deepa Reddy ma'am. Immense thanks to all of you. And I thank Arun Kumar for being there and supporting the program. Thank you all.
Thank you. Thank you.
Thank you.
Rachna and Dr. Shobha for
I thank Shobha
preparing the
for
program
being
so well.
great coordinator here.
Thank you very much.
Thank you, everybody.
Thank you.
Madam, you are
Thank
looking
you,
so
everybody.
beautiful today. Bharti madam,
Yeah,
what is
I
the
want to tell you,
God,
Bharti
thank
ma'am
you.
is looking very smart.
No, she always looks beautiful.
Thank you.
But
Thank you for
today
all
she
the
is looking
compliments.
extra beautiful, madam. Is it
Yeah,
your birthday,
beautiful
madam?
straight hair.
The weather
I want
outside
to
is
say that
nice
too.
and pleasant, and I am in a relaxed mood. Thank you very much.
Okay.
Seeing so many
everyone.
luminaries, all your glow is shining on my face. The glow of everybody else is on my face.
You're on
No,
the
it
run,
was an
ma'am. You're
emergency
almost on the
landing
run,
today.
and yet
Emergency landing, but the program was beautiful.
Oh yes, yes. Thank
Very
you.
nice, Vidya ma'am.
actually,
Thank you very
Thank
much. And
Vidya madam
Thank you,
for
everyone.
pushing us to do this program.
Vidya ma'am should be applauded for this today.
Madam.
she is the emergency
almost
pilot.
getting cancelled, and yet
Emergency
ma'am
pilot.
stood by. She
ವಿದ್ಯಾ ನಮ್ದು ಅಪ್ಲೋಡ್
stand.
ಹೆಂಗಂದ್ರೆ ಇವತ್ತು ಫಿಶ್ ತಿನ್ಬೇಕು ನೀನು
ಹೌದು.
In 2 days we made this program, madam.
Thank
Yeah,
you
madam.
very much.
Last
Arul,
minute did every minute thing was done by her. We are just sitting at
Arul,
the
are you
back.
coming to Bangalore this week? No.
Not this week. I'll come for CME.
ಶೋಭಾ and Rachna, good
CME
job.
when? Are you coming for the Southcon in
Thank you.
Mahabalipuram?
Thank you, ma'am.
No, we would like to see you. It's been a long time, Arul. When the rains were coming, I remembered our holiday in Andaman.
Andaman.
The flight didn't land. Dr. Vidyathobi, the flight did not land in Andaman. We were in the sky for almost 3 hours.
Oh my God.
Then
And
we went to Thailand,
Bangkok.
Oh my God.
Bangkok, refueled, came back and hovered around, came back to Chennai, then went again to Andaman.
And then Andaman, we
Oh
had a
my
very
God.
nice time.
Okay.
Arun Moli ma'am should actually sing a song for us.
Yeah, true, very true. Yes, I think Arul, you
Amazing
can
singer every
conclude with that.
Arun, please stop the recording because it will be uploaded in YouTube. And now let
Arul, please
sing.
conclude. Arul Moli, you can conclude with